syndrome in a case of resolving traumatic third nerve palsy. So inverse DRS is a rare atypical form of DRS where the abnormal eye movements, including globe retraction, narrowing of palpebral fissure, and pseudotosis occur on attempted abduction rather than adduction as seen in typical DRS. It is primarily acquired and often due to muscle entrapment or aberrant regeneration of third nerve following trauma or compression by aneurysm or tumor. Rarely it can be congenital. Here a patient with 22-year-old male patient presented to us with a 3 years back history of sudden onset of outward deviation, double vision on looking towards left side and right upper lid ptosis. All these symptoms were of 6 months duration. Apparently this patient was normal before. He had left face turn and right side frontalis overaction was noted with moderate ptosis. Both for test revealed diplopia and stereopsis was less than 2000 of second of arc. Diplopia charting revealed double vision more in the left case. His best corrected visual acuity was 6.6 and N6 in both the eyes and color vision was normal. On squint evaluation, he had right exotropia which was alternating. For distance, it was about 55 prism brace in with vertical component of 7 prisms, and for near, it was slightly more about 62 prisms, and there was no obvious pattern. Here are the pictures showing this is the primary position with ptosis, and on abduction, there is mild limitation in the right eye, and you can see the palpebral fissure width which is widening in adduction, which is unusual, unlikely of DRS. These are the 9 gaze photos. Elevation is totally absent and depression is also mildly limited, about -2. This is the abduction in limitation in right gaze. This is just to show the video. As you can see, there is widening of palpebral fissure in adduction and narrowing in abduction and mild limitation also in abduction. So it goes in favor of type 3 DRS. So anterior segment in right eye, there was moderate ptosis with poor Bell's phenomenon, and pupil was 4 mm round regular and sluggishly reacting both for direct and indirect. Other features were normal. Fundus was normal in both eyes. So we came to a diagnosis of compound myopic astigmatism in both eyes and right eye resolving traumatic third nerve palsy with pupil involved with inverse Duane syndrome type 3. We did MRI and CT. There was mild tortuosity in right optic nerve with mild perioptic nerve collection of fluid, which was seen in this picture, and orbital walls and extraocular muscles were normal in both the sides. On table, when we took up this patient for surgery, we found that FTT was negative. That means there is no entrapment of the muscle, and we planned for lateral rectus recession of 10 mm and application of 6 mm under local anesthesia. However, we did not consider ptosis correction because this patient had poor Bell's phenomenon. This is the immediate post-op picture. Patient had right minimal esotropia, but eventually it became exophoria. So this is the patient about at late post-operative period, 8 months. Hirschberg appears ortho. Of course, there is ptosis because we didn't touch that. So post-operative 1 and 2 months, we found diplopia gradually reducing. By 8 months, there was no diplopia for this patient. Actually, this was the most troubling symptom for the patient. So coming to discussion, aberrant regeneration of third nerve is known to occur most frequently following traumatic head injury and aneurysm of posterior carotid artery. Full-blown pictures of the syndrome might not be present in each case, but the lid signs such as pseudo-Greffet sign and inverse Duane sign are characteristic. Motility abnormalities in IDRS are thought to be driven by abnormal medial rectus muscle as opposed to lateral rectus muscle in DRS. This is yet another difference between inverse Duanes and the regular Duanes. The basic pathology of palpebral fissure narrowing in DRS is aberrant innervation, while in IDRS it is postulated to be restrictive in nature. These are the few studies which are similar to our studies, but the type of DRS was found to be different. Either it is type 1 or type 2. In our case, we found it is type 3. Both adduction as well as abduction was limited. So what is unique findings in our case? Patient had 6/6 and N6 vision despite head injury and optic nerve changes on MRI and CT scan. And the second thing is it was the type 3 DRS, and we didn't touch the ptosis part because the patient had poor Bill's phenomenon. So this is a very important examination finding to understand whether we need to correct the ptosis part. So we just did the squint correction. Thank you very much.